everyone. My name is Ola Didrik Saugstad. I'm a professor of pediatrics and based in Oslo, Norway. And my main interest is neonatology. It's a great honor and pleasure for me to have been invited to this conference and to give lectures. And I would like to thank the organizers, especially my very good friend, Dr. Mortala, for inviting me. And I'm so sorry I couldn't attend the meeting in Hurghada. And you all know the reason why. I had looked forward to come back to Egypt, where I've been multiple times, and I have so many good friends there I've been looking forward to see. So with these words, I would like to start in this presentation, I will try to give you an overview of perinatal COVID-19. And I'm sure that all of you are familiar with this topic, but there is published so much in this field recently. So I hope and I think it could be useful to give you an update, a summary, and kind of state-of-the-art situation of this field. So let's start with the most recent data from the Centers for Disease Control and Prevention in United States, CDC. Here is the age distribution of confirmed cases of COVID-19. And you see here that the youngest children between 0 and 4%, only 1.4% of those who have confirmed cases belong to this age group. Between 5 and 17 years, it's 4.7%. So it's a little bit more. Regarding children, we know that hospitalization of children is much lower than in the general population. And the cumulative rate in US per 100,000 is 107. By contrast, those between 0 and 4 years is only 9.4, it's only 10%. And for those between 5 and 17 years, it's even lower, 4.4 per 100,000. So here we have the cumulative hospitalization between March up till July 4th, but different age groups. And down here at the bottom, we have the youngest children. Regarding confirmed deaths by age, we have this similar pattern between 0 and 4 years of age, only 0.2% mortality. And for those between 5 and 17 years, it's even lower than that, less than 0.1%. So before I continue, I would like to share with you some of the experience we have from Northwestern University in Chicago. I'm also linked to this institution, so I can follow the situation closely there. So Malika Shah, who is the responsible doctor for COVID-19 babies there, she told me just before this lecture that at Northwestern University, they have cared for almost 100 babies exposed to COVID-positive mothers. And none of the babies have so far tested positive. And this tells us that this disease is relatively rare in newborn babies. So what I would like to talk about is to give you some background information, which I already started to do, and show you what we know about incidents regarding newborns and how the virus is transmitted, and also how we can protect our newborns, which symptoms should we look for. And I will spend quite a lot of time going through guidelines, and I will show you the most recent guidelines from CDC in United States. So some basic background, I'm sure you're familiar with that, all of you, but just to remind us that coronavirus is a family of related viruses, and many of them cause respiratory illnesses. Coronavirus causes COVID-19, of course, SARS, MERS, and even some strains, influenza-like symptoms. Now, the coronavirus that causes COVID-19 is officially called SARS coronavirus 2, which stands for Severe Acute Respiratory Syndrome coronavirus 2. Now, the name of the illness caused by the coronavirus SARS coronavirus 2 is COVID-19 and stands for Coronavirus Disease 2019. COVID-19 is categorized as a mild to severe respiratory illness, one that is characterized especially by fever, cough, and shortness of breath, and it may progress to pneumonia and respiratory failure. And today we also know that other organs are may be attacked, not only the lungs, but the heart and the brain and so forth. So the first case of COVID-19 was described in Wuhan in China in December 2019. Now, very recently, Diriba and co-workers published a meta-analysis of the severity of these different coronavirus infections in pregnancy. And I'll show you some of these data. This is forest plots of the 3 different diseases. Here is SARS coronavirus 2, MERS coronavirus, and SARS coronavirus. And what I did was that they looked at what I called severe cases among pregnant women. And to make it easier to read this data, the MERS coronavirus, they had the highest prevalence of severe cases, 77%, and you see the confidence intervals from 23 to 97. The SARS coronavirus, 48% had severe disease, and in fact, SARS coronavirus 2 had the mildest, is the mildest among these, with only 25% prevalence of severe cases among infected pregnant women. Now, the same authors have published radiological findings and therapy of these pregnant women. I will not go into details, but just point out that 20% of these had unilateral pneumonia and 57.9%, almost 60%, had bilateral pneumonia. Now, data from New York City, a city which was, heavily affected by the pandemic, they reported that of COVID-19 pregnant women, 86% of them had a mild course, 9.3% had a severe course, and 4.7% critical, means that they need intensive care treatment. And it was interesting that in this study, they concluded that this distribution did not differ from adults in general. We'll see that it might be other opinions about that. However, 80% of women without symptoms at delivery went on to have symptoms in the days to follow. And this is important to be aware of, because this may affect other caregivers, for instance, the father. And also, if both the mother and father become sick, it is important and may have serious impact also on the newborn. So we have to be aware of that even after a mother has returned home, she may develop symptoms So recently I wrote an editorial together with Malika Shah from Northwestern, who's, as I mentioned, responsible for taking care of the COVID-19 pregnant and newborn children in Northwestern University. So what we wrote in this editorial was that reports of vertical transmission are rare, indicating that transmission from mother to child primarily occurs postnatally. And what is the evidence for vertical transmission from the mother to the fetus, or placental transmission? Well, the problem with this is that it's difficult to really be sure what is contamination, what is a real true test. We know that contamination of the fetus with maternal fluids also during the delivery and also in the newborn period may make it difficult to be sure whether, if there is a positive test in newborn, if it is transmitted from the mother before the delivery or after. Well, anyway, these authors, Carvalho and co-workers, they summarized some of the evidence. For instance, in one of the first studies from China, where 9 pregnant COVID-19 positive women, we couldn't find any positive newborns, and breast milk was negative. Another study with 19 positive COVID-19 mothers, all were negative for the babies, and so on. So most studies now conclude that the likelihood of a vertical transmission is very small, but I guess it occurs. Now, Hong and co-workers also from China, they have put up some criteria for the neonatal diagnosis of COVID-19, and they are listed here: terminal instability, hypoactivity, feeding difficulties, respiratory distress, chest X-ray with changes, and diagnosis in family or caregiver, intimate contact with people with suspected or confirmed COVID-19, or patients with unclear pneumonia. But anyway, the conclusion so far, as I read the literature, is that vertical and transplacental transmission is extremely rare. Transmission to breast milk is also extremely rare. And this, of course, has clinical, practical consequences. Now, for the situation for newborn infants, we have some very new data from US, which has not been published yet, but the manuscript of this so-called priority study is available. It has been accepted for publication. This is an ongoing nationwide study in US of pregnant or recently pregnant women who have confirmed or suspected SARS coronavirus 2 infection. And the first author is Valerie Fleerman from San Francisco. So let's take a look at some of these data. As mentioned, priority is a prospective cohort study. The aim is to enroll 1,200 women from more than 100 US hospitals. And they recruit women 13 years or older with suspected or confirmed SARS coronavirus 2 during pregnancy or in the first 6 weeks after pregnancy. So they have so far 263 infants in their cohort. Of these, 179 come from mothers testing positive, and 84 mothers testing negative for SARS coronavirus 2. So among those testing positive, 81.6% were symptomatic, while among those testing negative, only 63% were symptomatic, and this is significantly different. So as I mentioned, they were collecting data up to 6 to 8 weeks after delivery, but also at the time of enrollment, immediately after birth. So of these 263 infants, they are reporting so far, 44 infants, that's 17%, approximately 1 out of 7 or 6 were admitted to the NICU. Fast breathing or difficulty breathing was reported in 11%, and apnea was reported in 1.6%. Now, what is interesting is that these characteristics did not differ between mothers testing positive or negative. So you cannot really diagnose coronavirus in newborns just by clinical symptoms and signs. Now, those infants born to mothers who first tested positive the first 14 days prior to delivery, of these, 1 out of 4 were admitted to the NICU. So here we have some of the characteristics. I will not go into detail with that, but I think what is of interest is the gestational age. And you see here that gestational age is not different between SARS coronavirus 2 positive and negative mothers, 38.3 weeks, 38.2 weeks in the 2 groups. Preterm delivery, no difference, 13.9 versus 16.1%. There has been a speculation whether mothers infected deliver preterm. In this study so far, there's no indication of that. Birth weight is not different between the 2 groups, and birth defects no difference. So of course, the sample size is still very, very low. I think it's important that even 83% of SARS coronavirus 2 positive mothers gave breast milk, compared to 92% in the negative group. And NICU admission was the same in the 2 group. Rooming in with mothers, a little bit lower when the mother was positive compared to negative, but it's not that big difference, 71 versus 79%. And breastfeeding at the age of 6 to 8 weeks is exactly the same in both groups. And I think that is very promising, 87.5%. So, as I mentioned, 26% of those who were positive were admitted to the NICU, compared to only 12% of those who were first tested positive more than 14 days prior to delivery. Now, infants born to mothers who first tested positive the first 14 days prior to delivery were also born a little bit earlier, as compared to infants born to mothers who first tested positive more than 14 days prior to delivery. 37.5 versus 39 weeks. So maybe it will turn out at the end that these babies are born a little bit preterm. So during the follow-up, 6 to 8 weeks of age, no pneumonia or lower respiratory tract infection was reported in the newborns. And out of the 56 infants assessed so far for upper respiratory infection, it was reported in only 2, that's 5% of these babies. So it's not very common. And in these first 6 to 8 weeks, 1.1% of infants born to SARS coronavirus 2 positive mothers tested themselves positive. So based on these numbers, the authors have estimated the incidence of a positive test for SARS coronavirus 2 among infants of mothers with a positive testing, only to be 1.1%. And you see the 95% confidence interval is from 0.1 to 4%. And none of these infants required rehospitalization in the follow-up period. So based on these data, I think we now know that neonatal infection is quite rare. Here is a systematic review by an Italian group just published, and I will not go into details here. They have summarized most of the literature, I think all the literature, up to deadline here. And I just want to show it to you for those who are interested in details. Now I'll talk about the guidelines for handling of newborns. So when I wrote this editorial at the end of April, beginning of May, with Malika Shah, we realized that there were approximately 3 different guidelines, protocols for handling of newborns related to COVID-19. So we have the Chinese guidelines, which are very strict compared to many others. For instance, mother-infant should be separated. Use of mother's breast milk is not recommended. And there's a quarantine from the mother if the mother is positive. By contrast, World Health Organization and most of the European guidelines, here is from Union of European Neonatal Perinatal Societies, UNPS, they recommended early room-in, they recommended breastfeeding, of course, taking care of breast hygiene, and infant and mother may be discharged together, no quarantine. American Academy of Pediatrics, they had a kind of a position a little bit between these two, I would call it extremes. The mother-infant should be separated, could be in the same room. They changed the guidelines several times, but it could be at the same room, provided they had kept distance 6 feet. They recommended not breastfeeding, but they recommended expressed breast milk, and it should be given by a healthy caregiver. And they also recommended quarantine from the mother. Now, very recently, you and co-workers, you from Singapore, published a summary, a systematic review of all the guidelines they were able to find from 17 countries, and they identified 20 different guidelines and recommendations up to May 25th this year. And let me show you what this looks like. I'll not go through this because it's a lot of data, but here is the antenatal and delivery room care. And here we have the countries: Australia, Brazil, Canada, China, France, India, Italy, Japan, Saudi Arabia. Continues here with Singapore, South Korea, South Africa, Spain, Sweden, Switzerland, UK, and United States. And also similar summaries for postnatal care. So this is, of course, very detailed for those of you who are interested. But I will spend the last minutes talking about the most recent guidelines from CDC, Centers for Disease Control and Prevention, from the United States, and these were updated September 11th. So what they say in these guidelines is that based on what we know at this time, pregnant people might be at increased risk for severe illness from COVID-19 compared to non-pregnant people. Additionally, pregnant people with COVID-19 may be at increased risk for other adverse outcomes, such as preterm birth. And they also admit that there's still much unknown about the risk of COVID-19 to newborns born to mothers with COVID-19, but we know that infections causing COVID-19 in newborns born to mothers with COVID-19 are uncommon, and the priority study indicate that. Some newborns have tested positive for the virus that causes COVID-19 shortly after birth. It is unknown if these newborns got the virus before, during, or after birth from close contact with an infected person. And most newborns who tested positive for the virus that causes COVID-19 had mild or no symptoms and they recovered. However, there are a few reports of newborns with severe COVID-19 illness. I think that is important to be aware of. We know that some of these babies need intensive care, for instance. And preterm birth, that is less than 37 completed weeks, and other problems with pregnancy among women who tested positive for COVID-19 during pregnancy. It is unknown whether these problems were related to the virus that causes COVID-19. So here are some of the suggestions for breastfeeding. So now CDC states that current evidence suggests that breast milk isn't likely to spread the virus to babies. You, along with your family and healthcare providers, should decide whether and how to start or continue breastfeeding. So CDC now opens also for direct breastfeeding, not only for using expressed breast milk. Because breast milk provides protection against many illnesses and is the best source of nutrition for most babies. We don't know for sure if mothers with COVID-19 can spread the virus to babies in breast milk, but the current evidence suggests that this isn't likely. And then they have some helpful tips for breastfeeding, and I will not go into details here. You can find that in the guidelines. Washing your hands is, of course, very important. So you should wash your hands beforehand and wear a mask while breastfeeding. That's what they say now in CDC. If you choose to express your breast milk, use a dedicated breast pump. You should not share it with other mothers. Wear a mask during expression and wash your hands with soap and water for at least 20 seconds before touching any pump or bottle parts and before expressing breast milk. Follow recommendation for proper pump cleaning after each use, cleaning all parts that come into contact with breast milk. And you should consider to have a healthy caregiver who does not have COVID-19 to give the milk. And this person should be living in the same home as the mother. And any caregiver feeding the baby should wear a mask when caring for the baby for the entire time you are in isolation and for 2 weeks after you completed isolation. You should also take steps to protect yourself from COVID-19. So limit close contact, interaction with other people as much as possible. And when going out or interacting with others outside your immediate household, you should wear a mask, especially when other social distancing measures are difficult to maintain. And avoid others who are not wearing masks or ask others around you to wear a mask if possible. Stay at least 6 feet, that's 1 meter and 83 centimeters, I think, away from others outside your household. Then hand washing, of course, is emphasized again, and avoid activities where taking protective measures may be difficult and where social distancing can't be maintained. Now, so this was a checklist published by Jeff Pearlman in Pediatrics very recently about how you should handle these mothers and babies in the operating room or labor delivery room, and during neonatal resuscitation, how we should transport the baby to the NICU and also the post-resuscitation care. I'm aware that this is very difficult for you to read these details, but I want you to know that such guidelines are present. What is important is that if there is a suspected or confirmed COVID-19 alone in an otherwise uncomplicated pregnancy, there is no indication for the resuscitation team or for the neonatal fellow. Delivery room preparation and management should include contact precautions. So, and then I will end up with this slide from Trevisanotto's review article from Italy very recently, showing how we should handle these cases. This is before delivery. There should be a hub for COVID-19 screening and taking care of those who are positive, and during. The mother should be isolated in isolated labor rooms if she's positive, and in the nursery you should keep distance between the mother and the child. They could be in the same room, but there should be 6 feet between them. So at the end, I'll just show you the symptoms and signs you should look for after hospital discharge, and the mother should be educated about this before discharge. And what you should look for is fever, poor feeding or vomiting, lethargy, drowsiness, breathing difficulty, groaning, worsening jaundice intensity. So if the baby becomes icteric, you should be think about COVID-19. Decreased diuresis, pallor, cyanosis. So in the presence of any of the above clinical signs, the following are recommended. Identify the health facility closest to the residence, and if positive for COVID-19, use a mask and inform the health professional who provides care to the family. So if the mother still does not have her COVID-19 screening results, advise her to contact the hospital by phone. So these are the recommendations from the Centers for Disease Control and Prevention. So with this, I will conclude this lecture, and thank you for your attention. And I'll be happy to try to answer your questions. Thank you so much. It's a great honor and a great pleasure to give this lecture. My name is Ola Didrik Saugstad. I'm a professor of pediatrics based in Oslo, Norway. I'm working with newborns predominantly. So I would like to thank my good friend, Dr. Mortada, for inviting me to this meeting. And as I already mentioned, I'm so sorry I couldn't attend the meeting. I've been looking forward to come back to Egypt and also to see many of my old friends there. My main interest in research has been oxygenation of the newborn during many years. So what I will do in this lecture, I will share with you some of the new data regarding oxygenation of the newborn, especially preterm babies, and also show you some indications that oxygenation plays a role for development of necrotizing enterocolitis. Here are my disclosures. So just to start with a few words about necrotizing enterocolitis of the newborn. And for those who, I'm sure you're all familiar with that, you can see this typical X-ray picture of necrotizing enterocolitis. Necrotizing enterocolitis NEC affects approximately 1 per 1,000 live-born infants, with approximately 1 in 4 infants with NEC undergoing surgical intervention. NEC thus represent one of the major neonatal gastrointestinal emergencies and is a significant contributor to rates of neonatal mortality. Now, the mortality rate of infants with surgical management of NEC has been reported to be 35%, and that is babies less than 1,500 grams. And this is the report from the Vermont Oxford Network in US. So necrotizing enterocolitis is among the most common and devastating diseases in newborns. It has also been one of the most difficult to eradicate, and thus has become a priority for research. Now, there were conditions resembling necrotizing enterocolitis described before the 1960s, before the introduction of modern neonatal intensive care, but it has not been recognized until after kind of modern neonatal intensive care was introduced in the 60s and 70s. So since that time, the incidence of necrotizing enterocolitis and the associated morbidity and mortality have remained unchanged. In some instances, these rates have actually increased. I think that's typical for US. In Norway, when I started in pediatrics, we very rarely saw any cases of necrotizing enterocolitis, but it has been increasing, much more common today, and it was 30, 40 years ago. So on the basis of large multi-center neonatal network databases from United States and Canada, it has been calculated that the mean prevalence of NEC is about 7% among infants with a birth weight between 500 and 1,500 grams. And the rate of death, the mortality associated with necrotizing enterocolitis is very high. It ranges between 20 and 30%. And it's highest in those who need surgery. We know that necrotizing enterocolitis also is an inflammatory process, and this extends the effect of the disease to other organs. It's a systemic disease also. It affects organs as the brain, and this places affected infants at an increased risk for neurodevelopmental delays. So according to this review article by Joseph Noy from US, nearly 25% of these babies develop microcephaly and serious neurodevelopmental disorders. What is the pathogenesis? What is the mechanism behind necrotizing enterocolitis? Well, it's not completely understood so far, but based on epidemiological observations, there's a strong indication that it has a multifactorial cause. So the combination of a genetic predisposition, intestinal immaturity, and an imbalance in microvascular tone, accompanied by a strong likelihood of abnormal microbial colonization in the intestine and a highly immunoreactive intestinal mucosa, leads to a confluence of predisposing factors. So here is one way you can consider that. So of course the genetics play a role here. Altered microbiota, low diversity, because antibiotics to the mother or to the children, most of these preterm or immature babies, they receive antibiotics, as you know. So this affects the intestinal barrier, which is immature, decreased mucus, decreased IgA, and so forth, leads to inflammation and tissue injury, and ending up with intestinal necrosis. So the factors which is mentioned often is intestinal immaturity, and I I talked about that already, microbial colonization. And then another factor which I've been interested in is hypoxia or ischemia. Some years ago, hypoxia ischemia was considered to be maybe the primary cause or contributor to necrotizing enterocolitis. But the recent years, it's not so, this is not so popular. It has been questioned how important it is. But we know that hypoxia and ischemia modulate the balance in microvascular tone related to the relative production of vascular regulators such as nitric oxide and endothelin. And this may contribute to necrotizing enterocolitis. There are other risk factors that have been mentioned also, for instance, umbilical catheters, especially in preterm babies on oral feeding, and also elective transfusion of packed red cells. So this was the background of necrotizing enterocolitis. And I will say something about oxygen therapy of the newborn. And we'll start out with the goals of oxygen therapy for newborns. First of all, of course, it is to provide sufficient oxygen to the tissues and to avoid anaerobic metabolism. It is important to prevent hypoxic pulmonary vasoconstriction and to promote brain and somatic growth. I think all neonatologists at least know that oxygen is toxic to the newborn, so it's important to minimize adverse effects. Oxygen is critical to life, but we know that too much oxygen in newborns can cause a number of detrimental effects by increased oxidative stress. This could lead to lung injury and lung diseases, bronchopulmonary dysplasia, which is a chronic lung disease, as you know, retinopathy of prematurity, brain damage, impaired brain development, and damage to heart, kidneys, and other organs. I will believe the intestine is one of these organs also. So many years ago now, more than 30 years ago, I came up with this hypothesis that there is a so-called oxygen radical disease of the newborn. And the idea at that time, I had been interested in one system which generates free radicals. That was the hyperxanthine oxide system, which is activated in preterm infants, especially if there is some hypoxia. So the idea was that this system generates free radicals, and it attacks, these free radicals may attack different organs at the same time. Now we know that there are a number of factors which contribute to oxidative stress, some of them mentioned here. Genes, placental insufficiency, epigenetics, maternal nutrition, maternal infection, maternal stress, but of course hypoxia. And we also know that inflammation is a major contributor to increased oxidative stress. So these free radicals attack different organs. That was the idea, and contributing to development of intraventricular hemorrhage and periventricular leukomalacia, retinopathy of prematurity, bronchopulmonary dysplasia, persistent ductus arteriosus, necrotizing enterocolitis, and hypoxic ischemic encephalopathy. We know that oxidative stress is involved in all these cases, but we don't know how important this factor is. It probably varies from one of these conditions to the other. So that leads me to the next question. How much oxygen should we give during resuscitation? And is it a difference between term and preterm babies? Well, traditionally, newborn babies in need of resuscitation after birth received a lot of oxygen. And one reason for that was the introduction of the APGAR score in 1953. Here you see Virginia APGAR is intubating a newborn. So if you look at Virginia APGAR's original publication from 1953, when she introduced the APGAR score, you'll see that 20% of these babies received supplemental oxygen. And that was very common at that time. And you also know that the APGAR score, in order to get a high APGAR score, 9 or 10, the color of the baby has to be pink. So in order to get a high APGAR score, the baby has to become pink. And how could a newly-born baby at the age of 1 minute or 5 minutes be pink? Well, the easiest is to give oxygen, to pink up the baby. And this is what has been done many places in the world. But we know that in fetal life, the fetus is hypoxemic, PO2 2.7 kilopascal, saturation 50 to 65%. And during the normal transition, the pulmonary hypertension resolves, and there's a gradual improvement in oxygen saturation, as shown here. So cyanosis is normal during fetal life and for the first few minutes after birth. But is it possible to get an APGAR score of 9 or 10 at 1 or 5 minutes? Well, if you look at how the saturation develops after birth, as shown here by the study by Mariani and Koch, if you look at the upper curve here, the preductal levels, you see at 2 minutes, the saturation is in mean just about 70%, and it's a wide variation here. Even at 5 minutes, where the mean is a little bit more than 85%, you see the wide variation. Many of these babies do not have a saturation above 80, and these are so-called normal babies. What happens if you resuscitate a newborn baby with 100% oxygen? Well, this has been tested both in animal studies and in clinical settings, and this is from an experimental study from Sweden, Richard Linner and coworkers. What they did, when the newborn lambs were delivered, they clamped the cord, and after approximately 10 minutes, these animals got a cardiac arrest, and they were then randomized to be resuscitated with air, the blue line, or 100% oxygen, the red line. And you see, if you resuscitate with 100% oxygen, PO2 increases to very high levels, more than 40 kilopascals, very high levels. By contrast, if you resuscitate with air, you get this more slow physiological increase in PO2, and you don't exceed this physiological level. So if you look at how newborn babies were resuscitated, for instance, up to 1998, I think the world map looked something like this. All guidelines recommended to use 100% oxygen. However, in the 1990s, I had organized and carried out 2 clinical studies where newborn babies in need of resuscitation had been randomized or quasi-randomized to be given air or 100% oxygen. And the last study, the RESO2 study, 2 Egyptian centers participated in this very important study. So Egypt really contributed to the new understanding of newborn resuscitation, which I will show you in a minute. But at that time, all babies who were resuscitated were given 100% oxygen, and they got this very high PO2 peak, as shown here. Well, so when I introduced this concept of using air for newborn resuscitation, I received a lot of resistance, I have to admit, and also objections. And there are 2 objections I got at every meeting, more or less, and that is, when you lack oxygen, you should, of course, give extra oxygen, and that is correct. But the situation is that you shouldn't give too much. And it turned out that it's enough supplementary oxygen in the air. And the second objection I met almost at every meeting was that you have to give oxygen in order to reduce pulmonary vascular resistance. Well, if we look at the last question, this was actually answered by Abraham Rudolph way back in 1966. This is from a study with newborn calves. And what you can see here is that here at the y-axis you have pulmonary vascular resistance, and on the x-axis the PO2 in millimeter mercury. And what you see here is that there is a decrease in pulmonary vascular resistance with increasing PO2. So that is correct. But it seems that when PO2 reaches a certain level, around 40-45 millimeter mercury, you don't get a further decrease in pulmonary resistance. And if you increase the PO2 even more, you will get an increased resistance again. And you find the same pattern regarding pulmonary arterial mean pressure versus PO2 as shown here. Around 40-45 millimeter mercury, you don't gain much more. You don't gain anything more regarding decreasing the pulmonary pressure. So after we had published our 2 studies, several other groups around the world did similar studies. And this is from a meta-analysis where we have summarized all the 10 studies which had been carried out at that time and still regarding term or near-term infants resuscitated with air versus 100% oxygen. We had more than 2,000 infants included in this meta-analysis. And what we found, and which we had known for some years by that time, was that mortality is significantly reduced when you resuscitate a newborn baby with air compared with 100% oxygen. It's a 30% reduction, and that is quite a dramatic reduction in mortality. So the world map started to change. The first country which switched their national guidelines from 100% oxygen to air was Canada, 2006. Some months later, in 2007, Australia followed, and then Sweden, Finland, Russia, UK, the Netherlands, Spain quickly followed. The rest of the world hesitated. For instance, my own country, Norway, maybe we should pick something in between 40%. And US, they were very critical to this idea, and actually one of the latest countries to change their guidelines. So in this period, some babies were resuscitated with 100% oxygen and got this very high PO2 peak, and some got this more physiological development. However, in 2010, the international guidelines from ILCOR came out and changed, and now they stated that in term infants receiving resuscitation at birth with positive pressure ventilation, it is best to begin with air rather than 100% oxygen. So then the world map changed like this, and I think most countries, I think also Egypt, changed to air from oxygen very quickly. So we got this more physiological approach to resuscitation. So we tried to illustrate what happens when you resuscitate with 100% oxygen versus room air. So if you resuscitate with room air, 21% oxygen, you get a slow and physiological increase in PO2. Some free radicals are generated, yes, but by contrast, if you resuscitate with 100% oxygen, you get this PO2 peak, very high levels, and a wave of free radicals. Now, how does this affect the baby? Well, we know that hyperoxia leads to cerebral vascular constriction, and we also found brain inflammation. caused by that, pulmonary vascular reactivity increases. It doesn't decrease, it increases. And it has been demonstrated in myocardial damage and acute renal injury. And I think also the intestine would, if it had been studied in detail, we'll find also injuries on the intestine. And hyperoxia, the first 10 minutes of life, is also associated with an increased risk of childhood leukemia. So for term infants, we know that if you resuscitate with air, brain inflammation and also hypoxic ischemic encephalopathy is reduced, mortality is reduced, cardiac injury and pulmonary hypertension is reduced, renal injury and risk of leukemia are induced. So I think there's now agreement that term and near-term infants should be initiated with 21% oxygen, room air, if they need resuscitation. But what about preterm infants? Well, we know that preterm infants are different compared to term infants. And we tried to summarize some of these differences in this slide, and I will not go through it in detail, but just remind you that preterm infants, they react differently to hypoxia than term infants. They go directly to bradycardia with an increased risk of intraventricular hemorrhage instead of this tachycardia period you will see in term babies. Well, their thoracic cage structure is soft. They have weak muscles. They have impaired alveolo-capillary interface, impaired pulmonary vascular response to oxygen, and they lack surfactant. So their lungs are immature. And they're also deficient in enzymes that protect against oxidative stress, such as superoxide dismutase or catalase. So hyperoxia has a more profound effect on a preterm baby compared to term baby, leading to oxidative stress and tissue damage. So in 2015, ILCOR, the International Resuscitation Organization, they came with more specific recommendations for preterm babies. So for those less than 35 weeks, one should avoid high supplementary oxygen concentration, defined as 65 to 100%. And they recommended to start with low oxygen concentration of 21 to 30% oxygen. Now the question is, of course, should we start high and titrate down, or should we start low and titrate up? Well, this is a study from Max Vento's group in Valencia 10 years ago, 11 years ago now, where they randomized babies less than 29 weeks to receive 30% or 90% oxygen if they needed positive pressure ventilation. What you see here is that there's no difference in the saturation between the groups, which is quite interesting, I think. I think one main reason for that is that when you look at how the FiO2 was changed, here we have the high FiO2 group, 90%, and here we have the 30% group. You see after 3 or 4 minutes, there's no difference because FiO2 is adjusted according to the saturation, the pulse oximetry data. And there was no difference between heart rates between the two groups. Now, several studies have now been published. So we have carried out several reviews and meta-analysis on this field. And I will show you some of the results, which is relevant to necrotizing enterocolitis. So we looked at randomized studies where the babies had been resuscitated with a high FiO2 versus a low FiO2. High FiO2 is defined as 60 to 100% oxygen, and a low FiO2, 21 to 30% oxygen. So the first finding was that it doesn't matter whether you start high or low. And we're now talking about babies less than 32 weeks, just to underline that. Regarding mortality, absolutely no difference. Relative risk 0.99. in these babies. But what about secondary outcomes as bronchopulmonary dysplasia, interventricular hemorrhage, grade 3 and 4? There was no difference, no effect on the outcome. So even if you expose a newborn baby to a high oxygen concentration a few minutes after birth, it doesn't increase the risk of bronchopulmonary dysplasia as shown here. However, when we looked at necrotizing enterocolitis, there was a 60% increased risk of NEC if you started with low FiO2, but this is not significant. But there's a strong tendency that it influences necrotizing enterocolitis. And this could be a matter of power. If you had more patients into this, it might be that necrotizing enterocolitis is affected by the oxygenation already in the delivery room, but we don't know. We need more data to be sure. What about preterm infants after delivery room? Excuse me. Should we aim at a high or a low saturation target? Well, this has been tested out in a randomized study called NEOPROM. NEOPROM consists of 5 individual studies with more or less the same protocol. It's the support trial from US, the COT trial from Canada, and the BOOST trial from England or UK, New Zealand, and Australia. And the question of this study was, what is the optimal target saturation for preterm neonates that would result in the lowest death neurodisability? So babies less than 28 weeks were randomized before the age of 24 hours to a low saturation target of 85 to 89% and a high saturation target of 91 to 95%. Oh, this is a big studies. Almost 5,000 patients have been enrolled in these studies. So what was the result of this? Well, in the low saturation target, there was more necrotizing enterocolitis and also higher mortality. In the high saturation babies, there was more ROP in need of therapy. So it means that whatever you do something wrong. So you have to find a balance, the right balance between high and low saturation. But anyway, these results changed the guidelines because most people in this field felt that it is more important to avoid mortality than avoid ROP. So guidelines changed from 2010, typically stating that saturation should be between 85 to 93%, and it changed to saturation between 90 and 95%. Here I have summarized the 3 meta-analyses carried out on these NEOPROM studies. And here we have death and or neurodevelopmental impairment, mortality, neurodevelopmental impairment, ROP, retinopathy of prematurity, interventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, and patent ductus arteriosus. And what you see here, mortality is increased 18% in the low saturation target groups. ROP is reduced 25% in the low saturation target group. No effect on interventricular hemorrhage, and no certain effect on BPD, but necrotizing enterocolitis is increased 25% in the low saturation target group. There's no effect on PDA. So here I have calculated the risk difference between high saturation and low saturation babies. So everything above 0 here favors a high saturation target and under a low saturation target. And the numbers here are p-values. So for death, yes, it is significantly higher in the low saturation group. and also necrotizing enterocolitis, as you see here. By contrast, ROP and to some extent BPD, depends on the definition, is increased in high saturation target babies. So we know that necrotizing enterocolitis is dependent on the saturation target. And we know that during resuscitation, there might be a possibility that if you have using a low saturation target or low saturation approach, low FiO2 approach immediately after birth, it may increase the risk of necrotizing enterocolitis. Very recently, a study came out is examining the effect of splanchnic oxygenation at the risk for necrotizing enterocolitis in extremely preterm newborns. So they used the near-infrared spectroscopy to assess splanchnic oxygenation. And here is the study. They ended up with 44 babies. Of these, only 8 of them developed necrotizing enterocolitis of some severity. 6 of them needed surgery. So this is a small study, but I found it quite interesting. So I'd like to share it with you. So the aim of the study was to investigate whether splanchnic oxygenation measured with near-infrared spectroscopy during the first week of life is associated with the risk of developing necrotizing enterocolitis in extremely preterm infants. And this study was carried out in Sweden, Karolinska University Hospital in Stockholm. And the babies received enteral feeding during the study. So here we have some data from the study. This is not so easy for you to read, but what you see here is that gestation age was more or less the same between the groups. Birth weight was approximately the same, 659 in the necrotizing enterocolitis group and 677 in the one who did not have necrotizing enterocolitis. So what they found was that splanchnic oxygenation, if it was less than 30%, there was a higher risk for developing necrotizing enterocolitis compared to those who had an oxygenation of above 30%. You see the crude risk ratio is 5.25. However, small for gestational age, birth weight, postnatal age did not affect the results. And there was no association between the oxygenation and age at full enteral nutrition. So here we have all the numbers, but the conclusion was that a low mean splanchnic oxygenation, SRSO2, assessed by near-infrared spectroscopy, if it was less than 30% during the first week of life, it is associated with an increased risk for developing necrotizing enterocolitis in extremely preterm infants on mainly continuous enteral nutrition, as you can see here. So just before I end, I just want to say a few words about congenital diaphragmatic hernia, because I think it's important for you. Very quickly, when you get such a baby, you should avoid bag and mask ventilation. These babies should be intubated. They need an orogastric tube. And we recommend to start resuscitation with 50% oxygen in these babies and a target saturation of 85 to 95%. And if there is persistent bradycardia or saturation is less than 80% at 5 minutes, you should increase the FiO2. And delayed cord clamping is also recommended. So with this, I would like to, and avoid a high peak inspiratory pressure and try to keep the PEEP, the positive end expiratory pressure, low. So with this, I would like to thank you for your attention. I think that there is still a lot of important data to discuss regarding the association between necrotizing enterocolitis and oxygenation of the intestine. I'd like to thank my close collaborators, Siddharth Ramji from Delhi, Max Vento from Spain, Satya and Lakshmi Rushima from California, Julie Ovi from Sydney, and Vishal Kapadia from Dallas, Texas. You see, we're a truly international group. So with these words, I would like to thank you for your attention, and I will thank you once more for giving me the opportunity to give these lectures. I thank the organizers, Professor Mortada once more, and I hope to see you in Egypt in the near future. Thank you so much.